Good morning, and thank you all for joining us. I'm Maria Tilden. I'm the Executive Vice President of Public Policy and Government Affairs here at CareFirst, and I would like to welcome you all to today's discussion detailing the role of demographic data in advancing health equity. Demographic factors and characteristics such as age, race, ethnicity, language, and gender influence and impact health status and outcomes of health services for both individuals and populations. The ability of the healthcare industry to capture this demographic data presents an opportunity to better understand and serve patients by proactively identifying high-risk members, developing targeted interventions, and creating appropriate and relevant education, care, and services. However, patient information and demographic data is often not available, incomplete, or even worse, inaccurate. To reduce disparities, it's critical to first know where they exist, and of course, you can't fix what you can't see. Today, CareFirst is thrilled to convene this panel of experts to discuss ways we can unlock the full potential of patient demographic data. And there's no more time than the present, given the way that the pandemic has laid bare healthcare disparities across this country. So I am just delighted to introduce you to our moderator, CareFirst Chief Medical Officer, Dr. Tich Changemeyer. I'm delighted to introduce Dr. Changemeyer, who is relatively new to CareFirst, but brings a rich and varied level of experience to this issue, and he will be leading us through the discussion today. So thank you. Tich?
Yeah, thank you, Maria. I'm thrilled to be leading this important dialogue today. And before we begin, a few housekeeping notes. We are happy to offer live closed captioning today. And to turn on this feature, please go to the bottom of your Zoom screen and click the closed captioning icon. Also, the Q&A feature is enabled. So if you have any questions throughout the event, please submit them there. If we do not get to your question today, we will respond by email within 3 business days. And finally, this session is being recorded and will be posted to CareFirst's Transformation webpage. We are here this morning to discuss health disparities and data. We know that all parts of our healthcare system need to work collaboratively to move the needle on health disparities. And to that end, Blue Cross Blue Shield Association has launched a national health equity strategy to confront disparities, and data is a core part of what it'll take to achieve that vision of equity. Providers only have a limited view of all of a patient's healthcare data because patients see multiple providers, and payers also have a limited view for various reasons, some of which is because data for race, ethnicity, and language is not required on claims or enrollment forms. Ultimately, measurement and analysis are critical to reducing inequities, and demographic data can help identify systemic shortcomings that result in inequitable access, outcomes, affordability, and experience of care. CareFirst is committed to building an infrastructure that supports health equity, making smart investments, and addressing the toughest health challenges. The collection of and access to demographic data provides the necessary level of detail to understand which groups are experiencing healthcare disparities or would benefit from targeted quality improvement efforts. We know that we can't fix what we can't tell ourselves the truth about. And the truth is we have lags in this area that require action. And to discuss the opportunities and challenges of acquiring and leveraging patient demographic data with us today, I'm excited to introduce our panelists. First, we have Maria Gomez, who's founder and president and CEO of Meris Center. Meris Center is a community health center providing healthcare, social services, and education in the Washington, D.C. metropolitan area. Under Maria's leadership, Meris Center has grown to serve more than 60,000 patients. Maria is also a health advisor to the DC Mayor's Office and member of the Mayor's Commission on Healthcare Systems Transformation, and serves on the Blue Cross Blue Shield Association National Advisory Panel on Health Equity. Maria, we are excited to have you share your insights serving diverse populations and the role of community health centers in capturing and leveraging patient demographic data. Look forward to the conversation with you. And next, I would like to introduce Dr. Anand Parekh, who's the Chief Medical Advisor at the Bipartisan Policy Center. Dr. Parekh's research focuses on chronic care management, population health, healthcare value, and the need for health and human services integration. Dr. Parekh is co-author of the recent report, Positioning America's Public Health System for the Next Pandemic, which includes demographic data collection as a tool to improve public health information technology and data systems. And then we're looking forward to hearing more about the report and its recommendations this morning. And last but not the least, I would like to introduce Dr. Trina Williams, who is co-founder and CEO of Socially Determined. Dr. Williams has leveraged his experience as a family physician and also a former health systems executive, as well as a consulting leader, to found Socially Determined. Socially Determined is an analytics platform that integrates the social determinants of health with clinical and claims data to quantify and visualize social risk and the specific impacts on health and healthcare outcomes. Trina, looking forward to learning more about your experience incorporating demographic data into healthcare technology, as well as leveraging the data to facilitate clinical redesign. To get started, we know that we have inconsistent and incomplete healthcare demographic data, and this can and has been attributed to a variety of factors, including voluntary patient reporting, as well as patient concerns around data misuse. Maria, I will start with you. From your experience, what are some of those primary challenges we face to collect patient demographic data, and how can these barriers be overcome?
Thank you. Thank you so much. I think that first of all, I would like to say that for many people that we serve, and we are a federally qualified health center, so we see people from all spectrums of life in countries and languages. But for many people, they do not see themselves in the U.S. Census categories, right? So white, Black, African American, and the whole 6 categories that we have. And so if people don't see themselves in those categories, they tend to choose nothing, or worse yet, they tend to choose, or both are actually bad, other or nothing. So for instance, I give an example. We see many people who are Hispanic, Latinos, and they may identify themselves as either Black or white. And you can imagine identifying themselves as either one of those categories only, the impact the effect that has on the care that you would provide that individual. They may also be reporting themselves only on the ethnicity side. And the reverse of that is having somebody who just reports as being Hispanic or Latino and not identifying themselves by their race. A Black Latino can have, in many ways, worse health outcomes than sometimes the white Latinos. So that to me is a piece that has been, we've struggled, even as someone who understands and has deeply committed, over 30 years of my work in this healthcare arena. This is something that we still struggle with. And I think that for many immigrants that from all over the world, and I'm not just saying Hispanics, but from all over the world, this is a new process, as many of you know. And so, and also for older adults, when it comes especially around gender issues and sexual orientation. And so there's a lot of need to inform the healthcare workforce why collecting the information is important. And so the colleagues that are speaking with me today that are on this panel hopefully will address this, because I think that there's there's still a lot of misinformation and a lot of, and I say this in a very positive way, ignorance about the why we collect this information, why it is important for the overall health assessment and outcomes of our patients. And also informing them not only why we need to collect it, but the negative impacts that it would have when we don't collect this information. Why not knowing the language preference of someone that they identify with is important to understanding their diagnosis and following through on their treatment. So just because someone is named Maria Gomez, sometimes, you know, people at the front desk and people, healthcare providers, just assume that that person only speaks Spanish, right? When really Spanish is really not their dominant language, and vice versa, of course. The same thing with knowing what the gender and sexual orientation, as we know, this really matters, and the kinds of questions that you need to ask and the treatments that you deliver to people. There are, I can tell you from so many years of working in this industry, that there's tremendous biases and prejudices and religious beliefs within our healthcare workforce that we really need to educate our workforce and do some training and around this issue. And also, in addition to that, really develop within our systems, our whole system, a zero tolerance for not adhering to these policies of addressing these biases. We have had many people that have not been with our Merit Center because of the way that they did not ask the question, the way they asked the question, the way they assumed certain things about certain people. We also need to make sure that we have multiple ways that this information is collected, right? So, so a lot of the reasons that our clients are saying that they don't like to give this information is because they don't have any privacy, right? There's no privacy in terms of when we collect this data. Yet, you know, giving someone an iPad to give them the privacy means that we have to address the issues of whether they are, you know, computer savvy, whether they can either read or write in the English language or even in their own language, right? So I think that we need to provide brief rationale why to our clients, to our patients, you know, a brief rationale of why we're collecting this data. I think it's so important in so many ways to not assume that people understand this, and particularly again for older adults and for immigrants throughout this nation. I think what I would say for many of us is that we need to make right, that we do PDSAs on the data that we collect. This is really, really important that we make adjustments and that we use those patient portals to collect this data in a way that people maybe can collect it in their own home, but providing information of why that's important. So I leave it at that for right now.
Thank you, Maria, for that perspective and highlighting some of the challenges which range from patient-oriented challenges, ranging from privacy to mistrust, as well as provider-related challenges, which could be either cultural competence and a variety of other factors. Trina, I'd love to hear your perspective on some of the challenges that we are seeing in collecting this data as well.
Thanks, Titch, and Maria, thank you for those comments. Actually, let me back up one second and just maybe thank Titch, you and Maria Tilden and the CareFirst team for inviting me and us as panelists to participate in this important conversation. So thank you. Maria hit on so many of the challenges. I think a lot about just sort of the simple word of trust. It gets to what Maria said, which is starting with the why. People need to understand how is this information going to be used and be able to break down the barriers of fear that it's going to be used right in a harmful way, right, as opposed to a way to think about the support. So part of that trust, I think, influences how we think about both message and messenger in terms of who asks the questions and how we ask the question and how we do it in a supportive and thoughtful way. That's one. And there are lots of challenges, but one of the others that we don't maybe talk about enough, and Maria may not see this as much on the provider side of the amazing work that Mary's Center does, but I think it's super relevant if you're a health plan, which is What about the members, in this case, the individuals who may be most vulnerable, who you don't see, right? Who you don't have an opportunity to have direct interaction with. As part of it, you have responsibility, care and management responsibility for those individuals because they are vulnerable, because they may have issues in trust. How do we gain better understanding? And I know we're going to talk about the data and some of the opportunities down the line, but I think it's important that we think about that. Who's the missing people, and actually are they some of the most vulnerable people that are not walking through our front doors, that we need to think about how do we engage them, pull them into the system, pull them into the support models that can exist, and gather that information and work with them.
Yeah, thank you, Trina. You bring up a good point in terms of how we actually can get data from those folks who are not engaging with the healthcare system. And Anand, I know in June 2021, you co-authored a report in which you highlighted America's COVID-19 response being hindered by significant gaps in demographic data and reporting. And in that report, you recommended that moving forward, the nation's data infrastructure can be strengthened via centralized federal reporting of race, ethnicity, and other demographic data. Can you share your perspectives on federal action to advance standards and requirements for demographic data collection? And I think this may tie into, what Trina was alluding to for those folks who may actually not be engaging with the healthcare system as well.
Hitchit, thank you so much to you and Care First. And I think when we talk about public health data, sometimes we think of healthcare as sort of being antiquated from a data perspective. Public health is even more antiquated from a data perspective. You have dozens and dozens of systems, some of which are not electronic, difficult to diseases. And so in our most recent work, we actually were looking at this in the context of positioning the public health system for the next pandemic. The idea being that the next time around, if you're a policymaker, you really need to know three things. Number one, you need to know who's in charge. Number two, you need to have the data so you know where you are and where you want to be during a crisis. And three, you need to have the resources to act. And with respect to data, we saw time and time again during COVID-19, we just have not had access to race and ethnicity data when it comes to testing, when it comes to vaccinations. That's why our group has recommended that Congress actually provide CDC the authority to require states to provide race and ethnicity data during a public health emergency. But one of the recommendations I think that's important that our group made in our most recent report is that there really should be established a set of core public health data, sort of a core public health data set important to public health for surveillance, for epidemiology. And we recommended actually ONC, the Office of National Coordinator for Health IT, come up with this data set. But you can think of demographic data, other important data that ought to be part of this data set. There ought to be standards for collection of this data, as well as an implementation of these standards, and then tying it to funding to ensure there's accountability. And CDC has an important data modernization initiative that could be helpful there. But I think the key point is that just like on the healthcare side, on the public health side, if you don't have the data, we're not going to be able to see the inequities and disparities. And that is ultimately going to impact, as Maria Tilden said initially, not just individual health, but population health as well.
And thank you for your perspective, Anand. Trina or Maria, I'm also curious about your thoughts in terms of having centralized collection of demographic data.
Well, Maria, maybe I'll jump in here just real quickly. Even before the collection piece, I think one of the things that Anand said that is so important is the standardization, right? So from a nomenclature and expectation and like building out, and ONC, right? This is part of the work that ONC, as an example, one of the bodies that has been doing in different parts of the healthcare ecosystem since its inception. So I think creating that expectation from a standardization as part of that. In terms of collection, I think it's one of the many sort of ways that we should be thinking about it, but setting the expectation, addressing the challenges, and we'll talk about this related to privacy and security becomes so important as well. But Maria, maybe to you for any additional comments.
Yeah, and I totally agree. I think that if we can set the standard for not just in healthcare, but maybe for education, for all the other places where people's lives are touched, right? So if the same questions are being asked over and over again as a parent, as an adult, in the school system, in the healthcare system, in the systems that are the social, places where people go and get social services, then people will begin to see that this is normal, that this is normalized. And I think I can't emphasize that the federal government, all of us together need to have one voice on why this is so important to the well-being of individuals, right? It determines what medication you get. It determines what kind of care you get. Those kinds of things are essential. And I think that if the community could understand the effects at the other end, then they would be more upfront to give that information. We have a history, right? HIV was not a really good moment in time, and how that information was used for employment and all that. So, and for insurance, for that matter.
Yeah, and Maria, you bring up a good point, and you alluded to it earlier as well, that we don't always effectively communicate the use and the importance of this data, which actually is probably something that we would like to talk about. Trina, if you could help us understand, once we have collected, this data, how can we leverage demographic data together with data on social determinants of health to really make an impact and make a difference in people's healthcare?
Sure, Titch, I'll probably give a biased answer because this is the world that I live in as part of it. So first, let me answer a couple of questions too that have come up. One is, how do we understand, especially the population of whether they're patients or members or participants or citizens, like that don't walk through our front door, but we need that information, right? We want a baseline. I think we're fortunate in that there can be third-party companies. There are companies that are large data providers. I think of one of our partners, TransUnion, who is able to collect, and many things that you all know, much of the racial and ethnic and even language data that we collect in the United States is done through surveys. It's either done at the front door or it's done through other survey mechanisms. And the ability to aggregate that information and to be thoughtful about that collection allows organizations to create, frankly, a different starting point, and to bring race, ethnicity, language spoken at home into the conversation early on. For sure, that information needs to be thoughtfully used and validated. So we actually start with acceptable use. So when we think about, Titch, your question, which is, what can we do with it? One of the first most important things, right? Our responsibility in the healthcare ecosystem is thoughtfully using that information in the right way to provide support. One, as we think about quantifying social risk, whether that's related to housing instability or financial strain or food insecurity, what we have found, we do not, at our company and the work that we do with our partners, we don't include race and ethnicity as data elements in determining whether somebody has high risk for food insecurity or low risk. It's not part of that calculation. That being said, it's incredibly important. What we've found is it's valuable for organizations, whether you're a health plan like Care First, you're a federally qualified healthcare center, community health center like Mary's Center is part of that, to be able to integrate race and ethnicity data with social risk information. So now I can say, do we see disproportionately our individuals who identify as Black, who identify from an ethnicity standpoint as Hispanic? Are we seeing disproportionate impacts related to their social risk? So higher degrees of food insecurity or health literacy challenges or housing instability. So being thoughtful and honest with ourselves to go after the data, to be able to look and stratify social risk, clinical risk by race and ethnicity, because it fundamentally, and Maria, you said this, it might change, right? How we think about messenger, medications, care delivery, and support. So it becomes a fundamental part of the intervention strategy. And that intervention could be a lot of different things, from care management, right, to referrals to organizations that may be specifically designed to support a specific group of individuals, right, or an intervention partner around that and how it's influenced by race and ethnicity. But we have to be honest in terms of that collection and integration of that data with our broader social risk and clinical risk information.
Thank you, Trainer. And Maria, you did allude to, I guess, the importance in the use of this data from a clinical standpoint. It really determines how we can provide culturally competent care to our patients. And I'm curious about, the use of these kind of data at a policy level. Could you just shed a little bit more light and perspective on how this data can be used at policy level?
Sure, Atish, and let me just, so many good points here. I just want to maybe reinforce very briefly some of the points that Maria and Trenner have made, and then answer your question on policy. Just to piggyback back on Maria's initial comment about ensuring that we make patients and clients feel comfortable and make it easy to provide demographic data, I think it's also a good reminder for our health professional community. We're so busy, sometimes we're rushed when we see patients, how important it is to take a moment to collect that data, because everything we do, whether it's clinical preventive screenings, whether it's chronic care management, whether it's diagnosis of the individual illness or disease, that demographic data, think about colorectal cancer screening, think about diabetes, that demographic data is absolutely vital. So I think there's something here for healthcare professionals as well. I think that Trenner's point, where right now there's a lot of focus on social determinants of health and social risk, but I think stratifying to see which subpopulations by race and ethnicity are most impacted by some of those social determinants and social needs, I think are so important. A case in point, we released another report on food and nutrition insecurity last week. USDA recently found that food insecurity during COVID-19, comparing 2020 and 2019, actually didn't worsen, and that's because of the investments made in federal feeding programs around the country, which was so important, so individuals didn't go hungry. But however, food insecurity still did worsen in Black households and households with children. So again, understanding the subpopulation data related to race and ethnicity is so important to go beyond social risk and understand which subpopulations are being most impacted. I think with respect to policy, I'll just say that as all of you know, we're going through a transformation. We've been saying this for many years in how we pay for medical care, from paying based on volume to value. And while there are some opportunities right now for those who are still on the volume side of the equation, there are sort of Z-scores, there's risk adjustment based on social needs. I think where a lot of the promise is from a policy perspective is really paying based on value and population-based payments. So the idea using shared savings from accountable care organizations, using bundled payments, using Medicaid waivers, using global payments, all of those opportunities on the value side allow entities to focus on the social determinants of health and then focus specifically on issues such as race and ethnicity. And another recommendation I think I would make is, as many of you know, within the federal government at CMS, the Centers for Medicare and Medicaid Innovation tests important delivery and payment models. I think it's time for CMMI to really do an assessment. There have been over 50 models tested over the last 10 years, but there's actually been not a lot of analysis or stratification to ensure that various demographic groups are being included, whether it's at the provider side or the patient side. And so I think we need to do more analyses like that to make sure as we move from a policy perspective from volume to value, we are in fact including all of our subpopulations. We're looking at demographic data as well.
Yeah, thank you, Anand. I think rightly said, as we move from volume to value, traditionally we have, focused mostly on, that risk adjustment, focusing on, the complexity of patients or members from a healthcare and medical standpoint, and haven't quite incorporated social risk as much. Maria, from a provider standpoint, I'd love to hear your thoughts, from that standpoint, in terms of the importance of including social risk and, stratifying patients or members on social risk as we think about value-based reimbursement. What's your experience and perspective from that standpoint?
This is crucial. It goes to the heart of as I keep repeating, to the heart of how we treat and how specific we treat individuals, and then communities as a whole, right? So if we have this data, we're really, for some of us that do a lot of work out in the community, that we do outreach, that we do a lot of collaborations with other entities, we can actually use this data to move the needle on the issues that Dr. Williams and Dr. Marak have been talking about. I mean, I think for us, I would just say that, one, we need to listen to our frontline staff, right? So many of our frontline staff in a health center like this, or in a private practice or wherever, come from the community that we're serving. They know and understand how difficult it is to answer these questions. So I think listening to our frontline staff and pivoting to actions and activities that would allow us to really train the healthcare workforce to get the answers to these questions. I think the other is as I said, the health provider education on just that. I can't underestimate. We need more resources. We need more provider time. We need providers to feel comfortable asking those questions. And then I think demanding this data is going to be really, really crucial. And I would say that one of the things that has been really, that is sort of the highlight and the hallmark of federally qualified health centers is that we do collect this unified data information, and it's a mandate to get funding. And I'm a great believer, and maybe this is, I don't know where that comes from because I'm generally very liberal, but I think we need to demand that this data is collected if you're receiving any kind of public funding, including Medicaid and Medicare dollars. And then we need to use this data and help Dr. Parag and Dr. Williams and those folks that are doing policy to advocate. It does no good, I think, for so many of us to collect this data, even when we get to perfect, right, at some point, and then just keep it to ourselves because of this issue, because of privacy and this and that and the other. We need to let go of that data and share it widely. I think it's a moral responsibility if we're really serious about community outcomes, and not just continuing to do the same thing that we've been doing for centuries, which is just seeing patients one at a time.
Yeah, and Maria, talking about privacy, it's something that has come up in this conversation quite a bit. And we also know that patient self-reporting has been viewed as the most accurate way to collect these kind of data. Trina, I wanted to circle back to you. You made a comment earlier on the use of alternate sources such as third-party vendors. I wanted us to have a conversation perhaps and tease out the pros and cons of collecting data one way versus the other, and knowing that actually having all the different sources will give us the comprehensiveness that we are looking for as we are collecting this kind of data. Wanted to hear your thoughts on the issue of privacy, validity, and reliability of data as we think about all these different sources.
Yeah, Titch, it's such an important question. Much of my answer will be about the and, not an or. So I think for us to get thoughtful, accurate, reliable, valid data, it's an and strategy. There's great value, as Maria talked about before, in the front door, right? In the course of care, being able to collect and demand that we collect that information as part of it. Maria, you also noted that sometimes, again, people may be reticent to share certain information as part of that. What we have found when we think about the and strategy here is there are really great, thoughtful data companies that are out there. One, I think it's incredibly important to understand acceptable use. So when you get third-party data, Jasmine on the chat asked questions about minors, right? Many times from third parties, you're talking about 18 and older, to be able to collect that information appropriately as part of that, but also understanding. So when you work with a third party company, whether that's TransUnion or others, they've got rules that are in place set to make sure that you use that information in a thoughtful and acceptable way. I think that's really important for all of us to understand as part of that. I think the pro side of being able to use an organization, a partner that can provide that data is you can do it at scale. So you can do potentially millions of people. So at a health plan, or maybe hundreds of thousands to millions at a provider organization in hours and days. Doesn't mean that it is perfect data, but it allows you at scale to better understand what the landscape and create a baseline understanding. You can understand what gaps you have, but you can start to understand maybe from a messenger or a messaging standpoint, where you might want to prioritize. How I think that's an and strategy is incorporating that process, that data collection, with the ways that you go out and get first person collection of information and how you validate, right? So we're using information that we might have on an individual or around a population, but how you thoughtfully, which means you've got to think about script, messenger, right? How they say it, who says it, and what environment do you ask those questions to be able to validate with that first person, with that person in front of you, whether that's a phone or right there as part of that, becomes really important and not to be taken lightly as you incorporate those two strategies.
Yeah, thank you, Trina. Maria or Anand, any thoughts on the things that we should be watching for or looking at, to make sure that the data is being used in an ethical way, and we're also upholding the privacy of that data and making sure that we're not impacting the privacy of the data.
Yeah, I think it's going to be very crucial, and we've seen the cyber security is going to be very, very important for all of us to manage and to invest in. I think cyber security, I'll go at the high level, which is people stealing the data, but that is still something that threatens us every day here. The other is just it's just, again, I think I talked about it earlier, and now going down to like at the practice level, just having entities to really deal with the issue of zero tolerance when people breach the data, right? So we find that much of this data is not breached by some sophisticated way, right? Somebody who came into our computer and breached and got the information, but it's really our own workforce, right? So that is really, really important to make sure that there's zero tolerance, just like there's zero tolerance about other issues that we have in the workplace. Then I think the other piece I think that I like to address is really the other side of that, which is, how do we break those barriers in communities and practices where there has been such a zealous sort of grabbing of the information. So like, for instance, in mental health, in the substance abuse and substance use, those areas, people have just been very, very, very guarded about, nobody sees that data, no sharing of that data, no matter what. And I think that we're trying to break through some of those processes, because it hinders, our Dr. Williams doesn't even get the data. I'm just giving an example. Dr. Williams in some practices doesn't get the information from the mental health provider that has an effect on his practice for caring for the physical health of that particular patient. And so I think we need a lot of work on that process, because there's just, even within our own center, we're fighting to share that data, you know?
No, you bring up a good point, Maria, that the data is not always, moving across different stakeholders who may, for various reasons, be needing to be using that data. And one even perfect example is amongst just providers themselves. When patients actually go and see different types of providers across different systems, there is not always, that seamless sharing of data amongst, the different providers. And, that just is a huge, problem in and of itself as well. The one area that I wanted to pivot to, perhaps even, getting back to, the conversation that we had with Anand on, federal action to advance standards. I just wanted to, get back to thinking about different sources of data. Anand, currently decentralized, data collection with patients is providing various levels of information during their interactions with payers and providers and social services. One area that we haven't quite touched on is, the area of public-private partnerships, just really leveraging all the different stakeholders that we have in the healthcare systems. I just wanted to hear your thoughts, Anand, on how we could leverage, different stakeholders as public-private partnerships in sharing and leveraging, that data in a standardized way. Any additional thoughts on that?
Yeah, I think on that point, just piggybacking off of the last conversation we had, I think health insurance exchanges at the state level, which are often public-private partnerships, can be effective. And as you know, these exchanges are important because when providers are not in a particular health system and a patient comes to see them, they can look up the data about a particular patient. Unfortunately, not all state health information exchanges are really statewide. And in some cases, they can exclude safety net providers or certain demographic populations. So I think from a policy perspective, particularly at the state level, making sure that state health information exchanges are truly statewide, that vulnerable populations, safety net providers, everyone is there. So that way, if a healthcare professional is seeing a patient not in their panel or not part of their system, they have that important race and ethnicity data, to complement the patient self-reported data. So I think that is probably one opportunity, I think, at the state level in terms of a public-private partnership.
Titch, if I can, I'd love to add on just a little bit of that. I think from a practical standpoint, so maybe not at the scale that Anand was just talking about all of the time, but where I think we've seen interest and opportunity is when health plan provider and government have actually come together. And instead of one organization thinking about somebody as a member and somebody else as a patient and somebody else as a citizen, we think about a common population together that they're just a person, right? They're a family, they're part of a community. But I think that there's opportunity when we see that Venn diagram and that overlap, right? Where we have a shared population, there's real opportunity, to share information, to also think about the message and messenger, to think about the intervention and the impact that you can have. And I think about an individual who's hearing care management messages, right, or care navigation messages from lots of different parts and lots of different organizations. Being able to come together around these common populations, share that demographic information, think about who's in best position to be the messenger for important care and care management activities become really important. But we're seeing real opportunities where organizations, multiple different organizations, are coming together in a thoughtful way to look at common populations.
No, that's a great point, Trina. And Maria, just wanted to come back to you on that point as well. Where do you see opportunities for collaboration with the providers if we think about all the different stakeholders that Trina mentioned, health plan, provider, government, government, as well as community-based organizations? Are there some things or missed opportunities that we could perhaps leverage or take advantage of as we think about demographic data in helping address health disparities?
Yeah, I think that there is a lot of missed opportunities. I would say that I would add into that, for many of our communities, we also have a lot of leverage and a lot of opportunity to work with individual philanthropists, right? And foundations. So you have government foundations, you have the health plans, and I think if we could begin to talk, I think all of us together about making an investment. What are the investments that need to be taken place to make sure that that entities like direct providers can invest in, right? Whether it's systems, whether it's iPads, whether it's the portals being a lot more nimble and easy for people who are not savvy and how can we have a common language together, both starting with the federal government and down to the different governments and private and insurance, about the investments that need to be made so that when we talk about population, but those investments need to be made in leveraging, making sure that the investments that are being made at the federal level are the same investments that, or help at least, or enhance those investments by foundations and other governments. I think there's just I don't see the conversations, right, going together, and as everybody's funding, right, for their own specific area, but I think in their own interest. But I think that if we really want to change the paradigm of a whole community, a whole nation in terms of healthcare, we could do it. We could do it. We have the power as health plans, as government, as foundations, individuals, and then our clients and providers.
Yeah, and I'm glad you brought that up, Maria. One of the topics that comes up a lot is, as we think about, not only collecting demographic data, but also analyzing the data, coming up with insights, and actually also addressing or coming up with solutions that are addressing social determinants barriers. There's always a question of, the balance of healthcare providers and health plans acting to address social determinants of health, risk factors versus, the state and local government. One question that I wanted to pose to you, Maria, I'll begin with you. Is it the responsibility of private organizations to develop interventions for social risks that are not met by the public sector, or to prioritize advocacy for broader social policy change? What are your thoughts there?
Are you just asking me, is the responsibility lie on the private sector? I think the responsibility lies on all of us. I think, the investments obviously need to be coming from the federal government, a commitment. But I think that the investment in terms of time, in terms of commitment, in terms of how it should be collected and delivered, and how that information should be used, should be the responsibility of the private sector, with the insurances, with the providers. Often the providers are left conversation. And so then you're imposing something on a group of very intelligent, individuals who are trying to do best for their clients, but things are imposed on them without ever having a conversation with them. So I think that again, I say it's a moral responsibility of all of us, but the federal government can only do so much if we as a group of providers and other private entities are not committed to a different.
Yeah, and Anand and Trina, I'd love to hear your perspective as well. as a family physician, I remember, when I was seeing patients, there were some of my colleagues who would say, well, I have only 15 minutes with a patient, and I don't have the time to ask about social determinants or even address the social determinants. So just wanted to hear your perspectives as clinicians. What are your thoughts on whose responsibility it is to be addressing social determinants within the healthcare sector?
And I'll let, go first.
Sure. Maybe I'll start. And I do agree with Maria. I think it's all of the above. If you look at the social services, the healthcare services sort of spending ratio in this country, it's about 1-to-1. A lot of other countries in the world comparable to ours, the ratio is 2-to-1. And there's good data to suggest that the higher the ratio, the better health outcomes. And even if you look at individual states in this country, those states that have a higher social services to healthcare services ratio have better health outcomes. So I think certainly there is a public role here to further investments in critical areas like housing and nutrition and food. And I think, as we all know, these are critical to health. But then the second question is, well, then how do you also simultaneously leverage the $4 trillion the healthcare sector spends, which is a mix of both private and public? And I think therein sort of lies, I think, the opportunity for public and private sector entities to focus on social needs as well as social determinants of health. And again, I think it may very well be that for healthcare entities, they may not be able to go all the way proximately, up the chain and focus on issues related to employment and education. But certainly there are probably midstream areas such as housing, such as nutrition, such as transportation, such as demographic specific data, where yes, I mean, healthcare entities should be able to see not only the linkage to improved health outcomes, but really many times in the short term, a return on investment and reductions in preventable healthcare costs. So I think it's both. I think it's the public and the private sector. We need to use our healthcare dollars smartly. We need also important critical investments in social services as well.
Agree with all of that, and I'll add a few things. It's really, really thoughtful answers to that important question. A couple of things, Titch, that I think about, though. At the pure provider, it's not enough just to say that it's provider and payer and government, all of us together. All of that is true, 100%. But even within the provider organizations that I've been a part of or seen or that we get a chance to work with on a daily basis, I also think it's a much broader perspective than saying, is this the doctor's or the caregiver's responsibility, or is it part of the system or the practice? I think about the difference between being informed and acting. I think it's an amazing opportunity to actually inform frontline physicians, nurse practitioners, PAs, care teams about the risks that people have, and to think about people holistically, not just the disease or the condition that I have, but about my life and what's going on, and the needs that I have, the risks that I have, the barriers and challenges and the opportunities that I have, number one. So as a physician, I'd love to know that my diabetics, right, especially the ones that have an elevated hemoglobin A1C, have risk related to food insecurity and maybe transportation. But I'd also love to know that within our healthcare ecosystem and with whether that's a practice or the health system, that we've got a plan to address that. That plan may include care management that's going to make sure that they have this conversation, or it's referral to a community-based organization, or it's leveraging an intervention partner. And I think where we've seen the most scale and success is when it's not on the doc to make maybe that social referral, but to know within the organization that that's happening. The other part of that is, I think it's the incumbent, this goes back to the combined population. How does a health system and a health plan work well together, or combine it, especially in a Medicaid population, the state Medicaid office, how do we all work together around a common population and share responsibilities as opposed to duplicating them? And so I think that takes communication, it takes sharing of information, sharing of ideas, and sharing of responsibilities to be able to do that well. And the last thing that I'll say is sort of tied to this. If we're going to do this and we're going to do it at scale and it's going to have long lasting impact, we have to fundamentally change how we get reimbursed, how we pay for this, right? We have to think and we have to be able to invest. To get to Anand's point, part of the challenge, right, in our 1-to-1 ratio, right, is we have terrible or no reimbursement sometimes for investments into social risk. So where we see real opportunities is if you start to think about risk-adjusted reimbursement, not just related to the clinical diseases and the acuity that I have, but actually encompass full social risk, not separately, but in an integrated, thoughtful way, so we can all make investments in this area that allow for us to address the human needs that people have, but also fundamentally shift the curve, bend that curve, and be able to address the healthcare cost and outcomes that exist too.
I couldn't agree with the two of them more than Mary Center is a really great example, and I know we have to go, of how we are one of the federally qualified centers that gets paid the least, because right now the way the system is set up, because we have family support workers and we have home visitation and we even have a school for parents and children so that they can learn literacy and all that, that is considered like administrative stuff. And so we get penalized for that. So our rate as a federally qualified health center is much lower than entities that don't have all those infrastructures that are addressing the social determinants of health. So we have to flip that around. We know, Dr. Parekh, that spending at least 2 to 1 is effective. We have the data to show it. So you're absolutely right.
Yeah, and
the government to believe it.
Yeah, and thank you, Maria, for that example. There was a question in the chat that was asking about where is this being done well today, and some of the work that you're doing at Mary Center is an example of that. And Trainer, I know you mentioned scale. I think that's the biggest question. Has anyone actually figured out how to effectively do this at scale and then target interventions and ultimately reduce disparities? We may not have time to actually get into the answer of that question, but I think it's actually a really important topic as we think about how do we provide access, quality, affordability, and equity in healthcare for everyone. That scale piece is very, very important. I want to just thank everyone for sharing your unique insights and perspectives on demographics, data, and disparities. And thank you to each of you who registered for this event. As we face continued challenges ahead, CareFirst is committed to transforming the healthcare system to one that is rooted in delivering value and healthier outcomes for all at scale. Thank you all for your engagement this afternoon. Have a great day, and thanks for joining us.